Welcome everybody to the next installment of the CPD Toolkit, where we're unpacking the changes to the CPD framework that were introduced by the Medical Board of Australia, with the aim of helping you as medical educators to design and to deliver engaging CPD programs. So in the last episode, we asked the question, what is a CPD program? And we answered the first part of that, which was the requirements that were introduced by the Medical Board of Australia. So if you haven't checked that out, we encourage you to take a look at that for an in-depth understanding of the requirements. But in this episode, we're going to look at the activities, which is the second part to that answer. And while I'm sure many of you are familiar with the typical types of activities, such as webinars or dinner meetings, there is a whole range of different activities that doctors now need to complete in order to meet their ongoing CPD compliance obligations. So with that, let's jump on into it. So what we're going to cover today is we're going to do a quick recap on the changes that were introduced by the Medical Board of Australia to the CPD framework. But in this episode, we're going to focus on the three different activity types, and those are educational activities, reviewing performance, and measuring outcomes activities. And we're also going to provide you as medical educators areas that you need to consider when designing and delivering CPD programs. But before we get started, we love your questions, so please type your questions into the Q&A function at the bottom of your screen. And we also highly value any comments or feedback that you might have that help us to design future episodes in this series. So let's jump on into it. We asked the question in the last episode, what is a CPD program? And as I mentioned previously, we looked at the requirements, and they were the new set of requirements that were introduced by the Medical Board of Australia. I'm going to recap on those briefly coming up shortly, but for an in-depth understanding, we really encourage you to check out the first episode in this series. But in this episode, we're going to focus now more on the activities. And the activities are those set of recognised CPD formats that can be accredited for CPD hours. So recapping briefly on the changes to the requirements, because it's really important to understand the activities in the context of the requirements. And that is, last year, the Medical Board of Australia introduced some sweeping changes to the requirements for CPD. The first of those was that all doctors now need to join an AMC or an Australian Medical Council accredited CPD home. They need to complete at least 50 hours of CPD training each year, develop a professional development plan, also known as a PDP, and undertake at least one emergency response training course each year. But for the purposes of today, we're going to focus on the 50 CPD hour requirements and the activities that make up those hours. So from last year, all doctors are now required to complete 50 hours of education across three distinct categories. They are educational activities, reviewing performance activities, and measuring outcomes activities. As you can see in the graphic here, the exact composition of the number of hours in each of those categories differs between CPD home to CPD home. The example that you can see here is that which has been set by the RACGP, which is the largest specialist college in Australia. And they say that for a GP, they must complete a minimum of 12.5 hours of educational activities, a minimum of 5 hours of reviewing performance activities, and a minimum of 5 hours of measuring outcomes activities. However, for reviewing performance and measuring outcomes, it constitutes half of the required CPD hours that a GP must complete each year. So what we encourage or implore amongst our medical educators is that you need to be thinking about reviewing performance and measuring outcomes in the design of your education. It's also really important to note that these aren't distinct and isolated categories. When you combine two or more of them together, they're known as hybrid activities. So when you're thinking about designing a webinar or designing a face-to-face workshop, you also need to be thinking about integrating into that the reviewing performance and or measuring outcomes activities as well. Okay, so let's kick it off with educational activities, which is the first of the categories. And so an educational activity are ones that are designed to expand a doctor's knowledge and attitudes related to their scope of practice. These are the ones that are going to be familiar to most, if not all, who are watching this webinar, and they are lectures, webinars, so the typical types of CPD education. Also includes podcasts, workshops, which can be interactive, reading, journals, case studies, and also courses as well. What we encourage our medical educators when you're thinking about and considering the design of your education is to ensure that it's specialist-led education. And by specialist education, we mean having a specialist involved in the design of the education who is from the target audience that you're intending to reach. So for ourselves who have significant experience in multiple specialties of education, but particularly GP-based education, we typically will have a GP involved in the design stage of that education because they are going to be ones better placed to understand the needs and the challenges of their target audience. Also, when we look at design, we follow a typically simple but robust approach as to how we develop education. So we follow the steps, as you can see there on the screen, of diagnosis. So helping your audience or your learners to better understand how to diagnose a condition. We also encourage the presentations to include differential diagnosis or the set of symptoms that a patient might present with that might confuse or might lead a clinician to an alternate or potentially incorrect diagnosis. We also include the treatment and management options. So that includes pharmacological and non-pharmacological options. And importantly, one that can often get left out, and that is referral. And so that's referring potentially within the profession. So one doctor referring to another doctor or specialty, or it could potentially be outside of the medical profession. So that is a doctor referring to an allied health specialist. We also strongly discourage in educational activities having too much science or statistics embedded into the presentation itself. While the audience certainly wants to know that the presentation is based on reliable and contemporary evidence-based medicine, it can be a very, very quick way to lose an audience by having it too focused on the science itself. What we find amongst the doctors who attend programs which we've developed is that they want to know the practical elements of how they can take that knowledge and apply it in everyday clinical practice. And of course, with educational activities, like it is across the other two educational types, and that is to focus on accreditation as well. We were asked in the last episode, what is the value of accreditation? Well, really simply, the value of accreditation is that for a doctor, it gives them an understanding that at least the education has been developed according to a set of standards, and those are the CPD standards. So it has an inherent degree of quality associated with that education. The logo that it gets attached to the accreditation also provides a doctor with comfort of understanding if they're trying to determine which course to enroll in or not. The logo can have additional weight as to know that the education has been designed according to a minimum set of standards. So moving on from educational activities, we're going to now look at reviewing performance and measuring outcomes activities. And while educational activities might be a more passive style of learning, such as attending a lecture or a webinar, reviewing performance and measuring outcomes activities tend to require the learner to be more actively involved. And while this can have a far greater impact on the learning and the knowledge retention of the doctor, it also requires a larger degree of effort on the part of the doctor to engage with that activity. And so a number of the medical colleges, including the RACGP, are now looking to have these there's different types, or there's reviewing performance and measuring outcomes activities integrated into the clinical workflows of the doctor. And so I'm now going to hand it over to Rob, who's going to talk you through reviewing performance and measuring outcomes activities.
Terrific. Thanks for that, Steve. So let's start with the first category here, which is reviewing performance. And really simply, I like to think of this as the category in which the doctor's seeking feedback. So that feedback could be from themselves. It can be from peers and colleagues. It could even be from patients and people that work in their clinic, in which they're seeking some kind of evidence and validation around their style and type of management in order to then reflect on that and improve their practice ultimately. There's quite a few ways in which this can be done. There's a list on the screen at the moment that walks through things like a clinical case discussion, in which a doctor might get together regularly with some of their peers to discuss cases and get feedback on how they've treated those patients. There's a terrific example called multi-source feedback, in which the doctor will seek, literally, that feedback from lots of sources, from people that they interact with regularly, to try and then improve their general performance. Won't go through all of these examples here, but these are well established and can certainly be tweaked based on individual CPD homes' requirements for various specialties within medicine. And this then brings us to measuring outcomes, the third and final, and in some ways the most involved category for a doctor to then complete their CPD requirements. Some peak bodies and CPD homes will call this outcomes measurement, but measuring outcomes is the more common definition here. And this really is the doctor looking at their actual clinical practice, looking at data, and then reflecting on that and understanding how they need to improve, or what else can they do to further enhance their delivery of medicine to their patients. And as Steve said earlier, the reviewing performance and measuring outcomes categories can be termed integrated, because ideally our doctors are reviewing and measuring their performance as a standard feature of their day-to-day practice. In a more formal CPD setting, you can see on the screen here a number of ways in which this can be delivered. Commonly, a mini audit or a clinical audit can be undertaken, in which the doctor will recall patients that meet a certain set of parameters in order to apply some new knowledge and then measure the outputs or outcomes from those patients against previous patients, potentially, and against guidelines and best practice. So these are typically more involved. They'll be much more challenging for a doctor to complete in a given day, and often they will set aside time over a few months to complete a really robust and thoughtful measuring outcomes activity. If we drill into this example here, it's what's commonly known as PDSA, or plan, do, study and act. And if we start in the top left corner of this quadrant, we can actually start with plan, which is setting out the framework of the activity. This would be where the doctor is looking at the change that they'd like to implement and then following the process. So moving into do is applying that change into their practice. Study is then reflecting on how that practice has changed their patient outcomes and measuring this against guidelines and peer-reviewed data. And then the final point or part of the process here is act, in which the doctor will then reflect on how those changes have improved practice and if there are other things that they should be incorporating in this clinical area. So hopefully that's helped to describe reviewing performance and measuring outcomes in a little bit more detail. Often and regularly, education providers will be tasked with or will want to deliver education that meets more than one of those categories to deliver something that's hybrid, so as to maximise the learning outcomes of those learners who participate in the education. One of the more recent examples that we were involved with was delivering an EA, an educational activity module with the University of Melbourne and Mercy Health for a particular module on sexually transmitted infections from mothers to newborns. And in addition to the 1.5 EA CPD hours on offer through the consumption of a self-directed learning module, in this instance, the doctor could also undertake a measuring outcomes activity in which they could then, in their own time, in their practice, reflect and measure on certain required clinical outputs in this area of medicine in their practice. Terrific. So let's conclude the formal part of the presentation today and acknowledge there's much more to CPD education than a single event, be it a face-to-face meeting or a webinar. And educators have a lot to think about today. Which CPD home or CPD homes do you need to accredit your education with to be able to meet your audience? Do you need an integrated activity, one that provides not only some knowledge through an EA component, but potentially challenges and engages the doctor with a more reflective or measurement-based arm to the education as well? And how will you deliver that? Because the more components that are created and provided will certainly also increase the potential complexity around delivery. So thanks so much for sticking with us so far. We're going to jump over to the Q&A next. We'll see you there. Awesome. Well, Steve, let's get into some questions that have come through. First one, is it worth considering all 3 CPD categories for all new educational programs? What do you think?
It's a good question. I guess the answer to that is, as always, it depends on what the objective is that you're trying to achieve. So when thinking about educational design, the starting point isn't really what format do I want to deliver that education or what categories do I want to deliver that education. It really comes down to, from a design perspective, what impact it is that I want to have on my learner. So if it's really just a simple case of just wanting to impart a little bit of knowledge around a therapy or clinical area, accrediting that education for an educational activity may be all that you need to do. However, if it's something of which you're looking to get greater impact, or if you're wanting the learner to reflect on their clinical experience, then you might look to then include a reviewing performance activity. So you're actually asking them to actively reflect on their past experiences. Similarly, if you're actually wanting them to changes in clinical outcome, then you're going to be looking to include a measuring outcomes activity. There's an interesting thing with educational activities where the more that you require the learner to do, typically the lower the participation rate is going to be. And it's an unfortunate negative correlation that exists. So we don't just carte blanche say for every single piece of education you need to design in a reviewing performance and measuring outcomes activity. It needs to be done thoughtfully around the type of or the extent and the impact that it is that you want to have on the learner. So in summary, it depends, which I know is a bit of a cop-out, but it's true.
Yeah, it's a very good answer to a very long and very, very big question. If I just built on to the back of that, as educators, we're also usually working to a budget. And if we're rolling things out both face-to-face and digitally, then there's potential complexity to consider then just in the administration of such a program. So let's jump into the next question. What, if any, differences exist when accrediting education with multiple CPD homes? Now, I might make a start on this answer, there can be quite a difference in how information is accredited with different CPD homes, and the majority of the CPD homes are still made up with the specialist colleges, who will all have their own particular model for seeking accreditation of education. Some of those bodies, such as the RACGP, will allow providers to accredit content on their own behalf, and others will require potentially a 6 to 8 week review period as well. So there's certainly no one size fits all when it comes to looking at how the CPD homes might be approached. Have you got anything else to build onto that?
Yeah, accreditation with CPD homes has always been a bit of a challenging one, in the sense that some of the CPD homes, or which we would just formally call the medical colleges, some are really built and designed around accrediting education, while others are not. And we've had experiences in the past where we've looked to have education accredited with some of the medical colleges, and unfortunately they sort of look at us like we're slightly crazy and say that we don't have the systems or the resources or the processes to be able to accredit that education. The good thing about the changes that have been introduced by the Medical Board of Australia is that while there is a harmonisation of the learning categories, so EA, RP and MO, the way in which they're then handled by the various CPD homes tends to be quite different. Some are quite sophisticated, some less so. So again, when you're designing education and you're thinking about your target audience and you're thinking about accreditation, also consideration needs to be given to the processes of those CPD homes and their abilities to be able to accredit that education as well.
So I think this next question's come in from one of our pharma colleagues. It reads like this: my doctors/customers say that they go to their annual conferences and get all the CPD that they need each year. Can this be true?
Is there such a thing?
That's right. I'd love to know what you think, but I think this is probably a statement that might not be entirely true when you think about particularly measuring outcomes and some of the clinical review. Certainly, there are conferences that do serve up a lot of CPD for delegates, but I'm not sure if I've heard of one that provides, say, 50 hours and tick all of the boxes that are required today.
I would have to agree with that. Certainly conferences, we know that they serve us very well in the EA category, so knowledge and skills. So attending various workshops and lectures that go on at the conferences can certainly accumulate quite a number of EA hours. Can probably service reviewing performance and reflective type activities, but when it gets into measuring clinical outcomes, that typically needs to be done as a part of a doctor's clinical practice. It's not to say that it can't be, but going to the extent of saying it services all of my 50-hour requirements in a single annual conference, that's probably not correct. The one thing that I'd probably just add on to that is the world's very different now to what it was, say, 2 years ago. And that statement very well could have been absolutely true. So, for example, a GP may have attended a conference, and what would have been, say, 2 years ago, accumulating 130 points of activity, it would be very possible to do that, and to also for that conference to include a CPR component to the conference, and that's your 130 points done. So the person who has asked the question could be reflecting on life 2 years ago, but today I would say that that's not possible.
Yeah, I guess the occasional doctor might find that to be true when you look at research being included in the measuring outcomes category, if the doctor's done research that they've presented. But I think that most doctors would need to apply some learning outside of the conference to complete their annual requirements. All right, let's move on to our penultimate question, which relates to the appeal that CPD has across the categories. Are there any of these CPD categories considered more attractive, quote unquote, to doctors? It's a very interesting question. What do you think?
In terms of attractiveness, I think what we see is that there are some categories that are harder for doctors to accumulate hours in. Certainly in an area which we do quite a lot of work, which is in general practice, we know that it's often more difficult for GPs to accumulate measuring outcomes hours as a part of their CPD requirements. And that is simply because whereas educational activities like attending a webinar or a lecture or listening to a podcast can be done quite easily, and to an extent, reviewing performance or reflecting on past clinical experiences can be done in a relatively, simple and efficient way. As soon as you're starting to get to the point of measuring clinical outcomes, it definitely requires a lot more effort. But on the flip side of that, I'm just going to note that education providers, from what we can see, are not providing as many measuring outcomes activities in order for doctors to be able to find and participate in. So one of the things that I know that, again, through our own experience with the RACGP, we've been encouraged as education providers to deliver more measuring outcomes activities. So in terms of attractiveness, we know that we get a number of inquiries from our members around how can I do a measuring outcomes activity. So it's probably one of the things that we would encourage you as medical educators is to, when you're considering the formats and the categories of education, if you can build in measuring outcomes activities into your education design, it is potentially going to increase the attractiveness of that education to your doctors, whether they're GPs or any other doctors.
Yeah, it's a really tough question because straight away I want to go to a position in which I'm breaking that down into specialties. If you think about a surgeon who's a member of RACS, well, they have to do a surgical audit every year to ensure that they're keeping up with best practice and guidelines and being very evidence-based around how they do their surgery. But certainly, to build on your comments there, GPs were really struggling last year to find MO activities, and it's the savvy sponsor or provider now who's thoughtfully considering how to make an event more than just an event by adding in integrated activities.
Completely agree. And I think, as to the point making, is that unfortunately that was the market not keeping up with the changes that came through from the MBA. And so we're finding that the market is sort of slowly catching up and delivering more education across the three categories.
Great. So last question, certainly not least, and I'm going to direct this to you in recognition of your previous legal background. If I'm a sponsor for a new CPD activity, what data can the provider give me once the activity is being completed?
Yeah, so this is always a challenging one because there's a natural propensity from those organisations who have sponsored a CPD activity to want to get very detailed data about the participants and who they are and where they're from and how they can be contacted and so forth. And each of the colleges or the CPD homes, they also have their own rules that apply in relation to what data can be provided if it is CPD accredited. So the first, at the outset, of course, there's a privacy related issue, and privacy has to be dealt with in accordance with National Privacy Principles and Privacy Act, and there are ways in which those can be, lawfully and properly addressed. But then it comes down to, outside of privacy, what other information can be provided. And often that's going to depend on the CPD home itself as to what information can actually be provided. Now that broad statement applies in relation to accredited education. Where the education has not been accredited, it's a bit more of an open playing field. The restrictions don't so much apply. Privacy, yes, but what other information can be provided, it's a little bit more open. So what we would typically do is when we're working with a sponsor is to give a really clear understanding of what information can be captured and provided straight up. If there's anything of which the participant wouldn't typically expect for their information to be passed on to a sponsor, we need to make that really clear to the participant that if they're going to register in a program, that this is the information that is going to be provided. The last thing I'll say on this is when providing data back, and things that we do is that when you start to then provide aggregated data and de-identified data, again, things get a little bit easier and a little bit more flexible. So if as a sponsor, really all you're interested in is the de-identified and aggregated data, so such as, from what state are they from or what specialty groups they're from, a lot more information can be provided, and maybe that's all you actually need.
Yeah, thanks, Steve. That's, again, another big area, but one that's, I think, important to be considered carefully so as to not potentially compromise the investment in the education with potentially going a little bit too hard on information around those that have completed or participated. So this brings us to the end of episode 2. Thanks everyone for your attention and your questions. Please leave some feedback. We really love hearing about how we can continue to make this CPD Toolkit more and more effective for you. And on that note, we'll see you next time.